Before moving into the pathological part, we have also seen how the upper respiratory tract and lower respiratory tract has been divided. Because it is required to know the exact anatomy so that you will understand pathogenesis also. Right? In the initial lecture also, we have seen the upper respiratory tract is till the level of trachea, right? Starting from oropharynx, nasopharynx, right? There will be hypopharynx, followed by the larynx, and from larynx beyond onward, there is lower respiratory tract. Lower respiratory tract. So lower respiratory tract, we have seen it comprises of the trachea, both main bronchus, that is right and left bronchus, then bronchioles, that is primary, secondary, tertiary, followed by the terminal bronchiole, then the functional lungs, that is alveolar duct and alveolar sac, what we call the acini or alveolus. So as you know, in the concept of pneumonia, there are mainly two types of pneumonia, right? So one we call it is lobar. One is lobar pneumonia and other is lobular. Right? So what is the concept of lobar pneumonia? As we know, this is right lung and this is left lung. In right lung, there are 3 lobes, right? And in left lung, there are 2 lobes. One lobe is lingular, which is hidden or dominant part. Section of the any lobe, it can be upper, middle or lower. So this will involve the one lobe completely. So it can be total involvement of the one lobe, right? Or it can be this one also, any single side. Usually it is not bilateral, it will involve the single, but the involvement will be complete. That will involve the complete lobe, one lobe. Either it will be upper lobe or lower, but mostly it will involve the lower lobe. That will be complete involvement. So this concept is clear. What is by lobar? Lobar means one complete lobe involvement, right? So moving on to lobular. So what is lobule in the lung? It is the combination of 3 to 5 terminal bronchioles. Right? It comprises of 3 to 5 terminal bronchioles. So what it will be there? It will have the 3 to 5 terminal bronchioles, followed by the respiratory bronchioles, followed by the alveolar ducts, followed by the alveolar sac. Right? The like structures. So the one lobe have many lobules. Understand? One lobe can have many lobules. Lobules have 3 to 5 terminal bronchioles, beyond terminal bronchioles, parts beyond terminal bronchioles, 3 to 5. Till now the concept is clear. Anatomy, what I told you, lower respiratory tract, it is from the trachea that goes into the right and left bronchus. Bronchus onwards, there will be bronchioles. Bronchioles will be primary, secondary, tertiary. then terminal bronchiole, right? So beyond terminal bronchioles, there will be respiratory bronchiole, alveolar duct and alveolar sac. So these combination of 3 to 5 terminal bronchioles forms one lobule. So in lobular pneumonia, there will be patchy involvement of the lobules, right? So there will be patchy involvement of these lobules. Right? So, and usually they are bilateral. It can be. Lobar means complete lobe is involved, and lobules means small lobules that are infected. And that lobules comprises of 3 to 5 terminal bronchioles. This is theoretical text. We can see what is pulmonary lobule. It is a cluster of 3 to 5 terminal bronchioles, each with its appendage, that is acinus, is usually referred to as pulmonary lobule. This is diagrammatic representation, right? You can see this is terminal bronchiole followed by the respiratory bronchioles, alveolar duct and alveolar acini. So combination of these 3 to 5 structures, they will form one lobule. So this diagram is given in Robinson textbook. You can see in this one, lobar pneumonia, one part of the lung is affected, right? Here you can see the lower part, lower lobe of the lung is affected. While in case of bronchopneumonia, as the lobules will be affected, what you will see in the gross, there will be patchy consolidation, right? Patches will be there. In between there will be skip areas or normal areas. And in case of lobar, there will be throat, continuous area of involvement, one complete lobe. This is gross picture. You can see this is complete involvement of the one lobe of the lung. You can also see the complete grayish white area. And this is normal spongy lung with little bit of hemorrhagic area. But you can see there is a clear-cut demarcation area involving one lobe. So this is lobar. Remember the terminology. It's lobar involving complete lobe. And this is bronchopneumonia or lobular pneumonia. So another name for lobular pneumonia is bronchopneumonia. Right? So remember these things. Bronchopneumonia is also known as lobular pneumonia. And you can see here there are patchy areas. You can able to see here small nodules. Right? It is not complete. You can see, compare both pictures. This is throughout one lobe involvement. Here you can see there are some grayish white nodule kind of thing. You can see, and it is not demarcated. You can see in upper lobe also. Understand? So again, division from the normal histology. The respiratory tract is lined by the pseudostratified columnar epithelium. And normally it is called respiratory epithelium. And the alveolar sacs are lined by the type 1 pneumocytes and type 2 pneumocytes. Major component is of type 1 pneumocytes. So what is pneumonia? Pneumonia is an acute inflammation of the lung parenchyma, distal to the terminal bronchiole, right? Distal to the terminal bronchiole. So what it contains? Distal to the terminal bronchiole means it will have the respiratory bronchiole, alveolar duct and alveolar sac. And there can be consolidation of the lung. So why this infection or why this pneumonia occurs? Because there are certain factors that hampers with the normal body defense mechanisms. That's why these patients are prone for the development of the pneumonia. So what are the factors? That can be due to the injury to the normal mucociliary apparatus, right? Because if the normal mucociliary apparatus will not work, so whatever the bacteria, virus or fungi we are inhaling through the air, they causes infection. Or there can be interference with the body mechanism like phagocytic and bactericidal action of the alveolar macrophages. So patients may have impaired bactericidal activity or phagocytic activity, and it can be due to many factors like the cigarette smoking, hypoxia state, patients with malnutrition or starvation, that ultimately patients will have anemia, and patients who are suffering from pulmonary edema and viral respiratory infections. Other factors that can have the impact also, they can be loss of cough reflex or suppression of the cough reflex. There can be accumulation of the secretions inside the alveolar spaces that leads to the secondary infection, or there can be leukocytic dysfunction and pulmonary congestion and edema. So what happens exactly? Why there can be accumulation and aspiration of the substances? So when this is nasopharynx and this is oropharynx, that opens into the hypopharynx, right? And here is the larynx. So larynx at the upper part, there will be supraglottic area or glottis, right? So when we take food, the glottis will be closed, and the food, whatever food particles will be there, that goes into the esophagus, right? So this is normal mechanism. So whenever there will be hamper in this mechanism, that food particle goes into the respiratory tract, and that respiratory tract food particle that would stick up into the epithelial lining or respiratory tree, and that causes secondary infection. So when this happens in patients who are having some neurological problems, those patients who are in coma, those patients who are in long-standing hospitalization, right, bedridden patient, they will not have their cough reflex properly. They will not have their cough reflex, or this glottic mechanism, it will not work. So the food particles or water also, they will get aspirated, and due to that aspirated material, that goes and stick up in the distal part of the lung tree, and that causes secondary infection. There can be some genetic factors also, like germline mutation of MYB88 that hampers with the innate mechanism of immunity, and that causes the infections with the pneumococcal pneumonias. There can be other cell-mediated immune response defects also, and that hampering of the cell-mediated immune response, patients will be susceptible for the mycobacterial and herpes virus infections. So what are the roots, different types of roots? So patients can have infection and they will develop the pneumonia. So it can be either direct spread from the hematogenous route or hematogenous spread. Patient is already having infection in the blood, and that infection spreads to the lung, because there will be gaseous exchange occurs at the lung site, and that infection can have directly spread into the lung parenchyma. Or the infection we can get through the, or this the inhalation of the microbes present in the air. Normal air also have some bacteria, viruses or fungi also. So those patients who have hampered immunity, they will get these infections. Or as I told you, it can be due to the aspiration of the organisms from the nasopharynx and oropharynx. Also aspiration of some food particles also. That leads to secondary infection. Or there can be infection from the direct spread, direct injury. There can be traumatic injury, or there can be direct spread from the adjoining structures like heart, pleura, right, mediastinal organs. If that organ has infection, the adjoining structures like lung, they can get the direct infection. So how to classify pneumonia? We know now the pneumonia is the infection caused to the functional units of the lung, that is alveoli, distal to the terminal bronchioles. So based on, there are different ways to classify this pneumonia. So based on the anatomic position, based on the etiology on pathogenesis, and it will be based on the clinical settings where from the infection occurred. So we will see one by one. So how the pneumonias are classified according to the anatomic side. So it can be lobar pneumonia, as I told you, involvement of a complete lobe. It can be lobar pneumonia, or it can be bronchopneumonia, also known as lobular pneumonia. Right? Remember, it can be lobar or lobular, or it can be neither. That is not lobe, not lobule. It is interstitial. The part of the lung that is interstitial. Interstitial part is affected, we call interstitial pneumonia. So this is depending on the anatomic location where the pathology lies. The pneumonia is divided into lobar, lobular and interstitial. Lobular is also known as bronchopneumonia. Remember the both words, bronchopneumonia and lobular pneumonia. Because whatever diagram I have shown you in gross pictures also, that can be asked in questions. So based on the etiology. Now based on the etiology, how they are classified? It can be bacterial, it can be viral, or it can be other organisms like fungi. Right? Fungus can have the infection and they can lead to pneumonia. So it can be bacterial, it can be viral, or it can be fungal infection. So third type of classification. Till now we have seen two types, anatomical classification and etiology, depending on which type of infection. Anatomically we have seen, and this one, infection, type of infection. Now based on the clinical setting, which infection occurred. So it can be community acquired pneumonia. Community acquired, that is people's living. So if you get commonly infection, you, me or anyone, those who are living in this community, they can get, we commonly call them community acquired pneumonia. Second type will be healthcare associated pneumonia or nosocomial infection pneumonia, that includes the hospital acquired infection also, or hospital acquired pneumonia. Second type will be healthcare associated pneumonia or nosocomial pneumonia. And third is ventilator associated pneumonia. Those patients who are on ventilator, long term or long bedridden patients on ventilator supports, due to the mucosal injury or respiratory tract injury, they will get secondary infection, what we call ventilator associated pneumonia. So till now the concept is clear. The classification of the pneumonia based on the anatomic side, based on the etiological agent, and based on these clinical settings. Three classifications clear? So remember this one. So bacterial pneumonia can be either lobar or it can be lobular. So bacterial, so the pneumonia caused due to the bacteria. It can be both ways, right? It can be lobar, it can be lobular. It can be bronchopneumonia or it can be lobar pneumonia. But the infections which are caused by the viruses, they are always interstitial pneumonia, right? So infections caused by the bacteria, it can be both ways. It can be lobar or lobular. But the infections caused by the viruses, they cause the interstitial or atypical, what we call atypical pneumonia. There will be infection of the interstitial. Clear? Bacterial can be both ways. It can be lobar or lobular. So this is positive organisms given in the Robbins textbook. We can see the community acquired pneumonia most commonly caused by the pneumonia, that is Streptococcus pneumoniae. And these are other like aspiration pneumonia, healthcare associated pneumonia, hospital acquired pneumonia. There are different organisms you have to remember, but most important here is Streptococcus pneumoniae, which causes community acquired pneumonia. So as I told you, we will see now bacterial pneumonia. It can be either lobar pneumonia or lobular. So what is lobar pneumonia? Lobar pneumonia is an acute bacterial infection of a part of the lobe or the entire lobe, or even two lobes of one or both the lungs. Remember the definition. Lobar pneumonia is an acute bacterial infection of part of a lobe or entire lobe or even two lobes of one or both the lungs. The condition is frequently occurs in adults, while the bronchopneumonia or lobular pneumonia, it occurs in extreme ages. Either it occurs in children or it occurs in elderly, right? And it occurs in usually adults. So what are etiological agents that will have this lobar pneumonia? So most common, as I told you, it occurs due to the pneumococcal pneumonia, infection caused by the Streptococcus pneumoniae, right? Other organisms include Staphylococcus aureus or beta hemolytic streptococci, or it can have the pneumonia by the gram-negative aerobic bacteria like Haemophilus influenza, Klebsiella pneumoniae, right? Proteases, Escherichia coli, and H. influenza. So causes of pneumonia in children below 3 years of age after proceeding. So these are common in children and these are common in adults. So pathologic phases of the pneumonia. So till now it is clear lobar pneumonia is caused by the bacteria that is common due to the Streptococcus pneumoniae. So what are the stages? There are 4 stages of the pneumonia. Pathologically there are 4 stages. First stage is stage of congestion, followed by the stage of red hepatization, followed by the grey hepatization and resolution. The stage of congestion we called it as initial phase. The stage of red hepatization is called consolidation, and stage of grey hepatization we call late consolidation. So what is the word mean by hepatization? As we know, the normal lung is spongy, right? It is spongy in consistency. But when there is an infection, the lungs turn into the firm organ, firm like a stone, right? Firm. So what is liver? If you see the normal anatomy of liver also, it is firm, right? So we give the term that is hepatization. It means like liver, like. So normal liver, this lung will be spongy. On getting infection with the pneumonia, it turn out to be like liver. So we call it red hepatization in the early consolidation and grey hepatization depending on the color, right? We call it is late consolidation. So here you can see the 4 stages of the pneumonia. Stage 1 is the stage of congestion, that will be for 1 to 2 days, followed by the red hepatization, that will be for 2 to 4 days. Then the stage of late consolidation or grey hepatization from 4 to 8 days, and resolution will from 4th day or 7th day onwards till 3rd week. We will see one by one. So first stage is stage of congestion, what we call the initial phase. It long lasts for 1 to 2 days. So what happened here? So this is a gross picture from the lung, diagrammatic representation. So you can see here enlarged and heavy lung with mild plurosity. Along with you can see these are one lobe, complete involvement of the lobe with reddish discoloration. And if you cut this lung and see the histopathological examination, so what you are seeing here, these are normal alveoli, right? So you are alveoli, these are alveoli sacs, right? Alveoli, you can able to see these are alveoli, demarcation. And in between there are pulmonary circulating vessels, in between there are vessels. But if you see here, the normal alveoli, they are empty, right? They will have air. But here you can able to see there is pink eosinophilic material, right? So this is edema, edematous fluid. What we are seeing is the edematous fluid, pinkish material. And here if you are able to see, these are lobular cells, they are neutrophils, but they are very less in quantity, right? So in initial phase, there will be only few number of polymorphs, and what we are seeing here, red color dots, they are RBCs. So in initial phase, there will be only few number of polymorphs and red blood cells, RBC, right? So few polymorph neutrophils and there will be RBCs. Along with in the background, there will be edema. What is we seeing? Pinkish color. So normal alveolar spaces are replaced by this fluid, and there will be some engorgement or dilatation of these pulmonary circulating blood vessels, and they will be filled with these RBCs, right? So this is text part, what I have already explained to you. There will be dilatation and congestion of the capillaries in the alveolar walls. There can be presence of pale eosinophilic edematous fluid in the alveolar spaces. There will be few red blood cells and neutrophil in the intra-alveolar fluid, right, or edematous fluid. And there will be numerous bacteria. If we take that fluid and send it for culture, microbiological culture, you will grow numerous bacteria in that one, right? So first stage is clear. First stage is stage of congestion. Long last for 1 to 2 days, because MCQ will come on number of days also in this stage, right? Or you have given the histopathology image also and ask what is the stage of pneumonia. The second stage is stage what we call the early consolidation or red hepatization. This stage lasts for 2 to 4 days. Second stage lasts for 2 to 4 days. And the term hepatization in pneumonia refers to liver-like consistency of the affected lobe of the lung. So what you will see in the gross, the affected lobe is enlarged, heavy, dark red and congested, and cut surface exudate blood-stained frothy fluid. So what you see here, gross. So gross from the red hepatization of the lung. So in red hepatization, you can able to see the lung is firm in consistency affected, and there will be reddish discoloration. But compared to initial stage, the reddish discoloration is more here, right? And if you cut this lung and examine histopathological examination, compare with the previous slide, right? Compare with the previous slide. Now in the second stage of the red hepatization, the number of polymorphs and the red blood cells, they have increased in abundant quantity, right? If you compare in second stage, the number of polymorphs and this one red blood cells, they have increased in numbers. There will be abundance, right? And also there will be dilated air spaces along with these numerous polymorphs and red blood cells accumulation. And this is the real image, right? That was diagrammatic. And if you compare, this is real image. So if you did this, there are dilated alveolar septa. So this one, these are alveolar sac one. This one is a bigger one. You are not able to see exact demarcation, right? So there are destruction of the alveolar wall also. Some of the alveolar wall has been disrupted, but you can able to appreciate. So dark staining, wala blue this one. This is polymorphs, and red wala this one. These are RBC. So there are numerous presence of polymorphs and RBC. Clear? In second stage. So what you will see in grossly, this one lung will be red, firm and consolidated, and the cut surface of the involved lobe, there will be airless, red pink, dry granular and has liver-like consistency. That is hepatization, red hepatization of the lung. And the stage of red hepatization is accompanied by the serofibrinous plurosity also. The affected lobe side pleura is also affected, and that can have the serofibrinous plurosity. Followed to the next step. What is next step? Now there will be grey hepatization. That lasts for the 4 to 8 days. So first stage was initial congestion, that was for 1 to 2 days, followed by the red hepatization, that lasts for 2 to 4 days. Now the third stage is grey hepatization. It lasts for 4 to 8 days. So how the lung will be there in grey hepatization? Again, it will be firm and heavy. The cut surface will be granular but it will be rather than red, it will be grayish in appearance, and it will have liver-like consistency, and the change in its color from red to grey begins at the hilum and spread towards the periphery. So whatever the affected lobe of the lung will be there, the initial changes that will start from the hilar area and it will spread towards the periphery. And on the cuts, again the pleura can have fibrinous type, fibrinous pleurosity. So here, this is the grey hepatization. You can able to see this is grey hepatization, and the whatever reddish part that has been disappeared. And on microscopically, if you see these alveolar sacs or alveoli, so the number of RBCs here they are decreased. So the number of RBC present in the alveoli they will be decreased. The number of polymorphs also they will be decreasing in number. They will also decrease. But what will appear? So here in grey hepatization stage there will be appearance of the macrophages, right? So what they will do? They will engulf whatever the material was there, right? Pus-like material will be there that due to destruction of the polymorphs, that material, so macrophages, they will try to eat up and clear the air spaces, right? So these alveolar macrophages, they will phagocytes. So whatever dead material or whatever dead debris will be there, they will try to take out and they will try to clear out the spaces. So you can able to see there will be some clearing of the alveolar spaces, right? So there will be presence of macrophages, few number of polymorphs, and there will be markedly decrease in the number of RBCs in the stage of grey hepatization. Clear? Any doubt? So this is actual diagram, HNE pictures. So there will be presence of macrophages. You can able to see. So there are some clearing is occurring, right? So there are macrophages trying to take out this slough material, and there will be presence of macrophages, and number of polymorphs has also been decreased, but still there are some exudative material also there. So they are trying to recover the lung parenchyma. So what happens? First stage is 1 to 2 days. Second, red hepatization 2 to 4, and third stage from 4 to 7 days or 4 to 7 days or 4 to 8th day, and resolution stage will start from the 7th or 8th day onwards, and it will go till the 1 to 3 weeks. So antibiotic therapy, patients is getting antibiotic therapy. These resolution stages will be rapid. So what will happen in the stage of resolution? The fibrin strands are dense and more numerous will appear. The cellular exudates like neutrophil is reduced in number due to the disintegration of many inflammatory cells as evident by their pyknotic nuclei. The red cells are very decreased in number or very few. The macrophages begins to appear and they will try to engulf the material. The cellular exudates is often spread from the septal walls by thin clear spaces, and the organisms are less numerous and appears in degenerated forms, and they will be phagocytosed by these macrophages. So in a stage of resolution, there will be presence of fibrinous bands, and there will be decrease in the number of neutrophils. There will be appearance of macrophages, right? And there will be some alveolar spaces which are clearing. So in a stage of resolution, that it may last long for the 1 to 3 weeks, right? So here there are still you can able to see some blood vessels which are congested, but there will be numerous macrophages will come now in stage of resolution or in last stage, and the number of lymphocytes, so polymorphs will goes, and there will be presence of few lymphocytes and macrophages. If you see normal lung also, in normal lung air spaces also, you can able to see few macrophages. So here in the stage of resolution, there will be presence of macrophages and lymphocytes. And you can see compared to previous images, their air spaces are free, almost free. But if the things goes on, so this is a stage from the advanced organizing pneumonia, and if the patient didn't get any antibiotic or therapy, and didn't receive any treatment, then these alveolar spaces, they undergo the fibrosis, and you can able to see there will be destruction of these alveolar spaces and they will be replaced by areas of fibrosis, and they will have organizing pneumonias or afterwards. So till now, so we have seen these 4 stages. You compare images, all image, you can able to see there is a first stage, initial phase, phase of congestion. There are only few polymorphs and red blood cells along with alveolar edema. In next stage, stage of hepatization or early consolidation, there will be numerous presence of polymorphs and red blood cells. In first stage, there will be engorged blood vessels also. And in stage of grey hepatization or late consolidation, there will be present these polymorphs and RBC. They are decreasing number and there will be appearance of macrophages, and they will try to clear up the air spaces. And in stage of resolution, the number of macrophages will be increased in number and present. This is clear. 4 stages of pneumonia: stage of congestion, stage of red hepatization, stage of grey hepatization, and stage of resolution. Clear? So this image I have already shown you. This is gross picture from the lobar pneumonia in grey hepatization stage. So remember these days also. Stage of congestion 1 to 2 days, red hepatization 2 to 4 days, grey hepatization 4 to 8 days, and stage of resolution 8th day onwards till 3rd week. So moving on to another second part, that is bronchopneumonia or lobular pneumonia. So it is not like the lobar pneumonia. Lobular pneumonia has only 1 stage, right? So lobar pneumonia has the 4 stage, but lobular or bronchopneumonia, it has only 1 stage. So bronchopneumonia or lobular pneumonia is infection of the terminal bronchioles that extend into the surrounding alveoli, resulting in patchy consolidation of the lung. We have seen what is the terminal lobules, right? So in lobular pneumonia, there will be affected parts will be collection of 3 to 5 terminal bronchial onward structures, what we call the lobules. The condition is frequent at the extremities of age. I already told you, lobar pneumonia is common in adults, while lobular pneumonia is common at the extremities. It can affect the children or in debilitated elderly patients. And it is as a secondary infection follows the viral respiratory infection in these patients also. So what is etiology? What is etiology? In lobar we have seen Streptococcus pneumonia is the commonest organism which causes lobar pneumonia. While in case of bronchopneumonia or lobular pneumonia, this can be any organisms. It is like they can be Staphylococcus, Streptococcus, Pneumococci, Klebsiella, right? Haemophilus influenzae and gram-negative bacilli like Pseudomonas and coliform bacteria. So there can be combination of these bacteria also in lobular pneumonia. So what will be happening in gross? We have seen the both pictures of the gross lung affected lungs. There will be patchy areas of consolidation rather than single lobe, or they affect 1 or more lobes. It will not be restricted to 1 lobe only. It can affect more than 1 lobe. Frequently found in bilaterally. They affect both lungs. Usually they affect both lobes and more often involves the lower zones of the lung due to gravitation of the secretions. And cut surface, there will be patchy consolidation lesions that can be dry, granular, firm, reddish to greyish in color, and they vary in size from 3 to 4 cm in diameter, and they are slightly elevated over the surface compared to the normal lung parenchyma, which is spongy. These nodules will be raised from their surface. So this is image I already shown you when we are comparing lobar and lobular. So this is lobular pneumonia or bronchopneumonia. You are able to demarcate small nodules here, right? Patchy consolidation of the lung. So you can able to see it is involving both lobes. This is another gross image. you can better appreciation. You can able to betterly appreciate these grayish white nodules affecting the entire lobe, and they can be this here also. The second lobe is also got infected, right? And this is also involved. So these are patchy areas of consolidation. This is another higher magnification, cut surface of the lung, patchy, and in between you can able to see this is normal lung parenchyma. Clear? So what you will see in histopathology, if you see the image from the bronchopneumonia or lobular pneumonia. So in lobular pneumonia, terminal bronchial onward structures are affected, right? So there can be acute bronchiolitis, right? So there can be bronchiolitis, and there will be suppurative exudate consisting chiefly of the neutrophils in the peribronchial alveoli, and there will be thickening of these alveolar septae and congested capillaries and leukocytic infiltration in between these, and the less involved alveoli contains the edematous fluid. So this is diagrammatic representation from the lobular pneumonia. You can able to see this is bronchiole. You can able to see this is, right? So this is bronchiole, and there are few alveoli also that are also affected in this one. So part beyond the terminal bronchiole that is involved in this lobular. So it will have respiratory bronchiole, alveolar duct, and alveolar sac. So this is bronchiole. You can able to see there are numerous number of polymorphs which are infiltrating throughout this wall of the bronchioles. Also they are infiltrating and infecting these pulmonary alveoli. Clear? So what is the difference between the lobar and lobular pneumonia? Again, this is important. So age wise, as we have discussed, lobar pneumonia, while in lobular pneumonia they affect extremities of the age. Organisms mostly Streptococcus pneumoniae, and in lobular pneumonia there will be mixed organisms. In grossly there will be one lobe is affected, and that will be throughout, diffuse, what we call diffuse or throughout. Here in lobular there will be patchy consolidation, patchy involvement of the lung. The typical inflammation, there will be fibrinous inflammation, while in case of lobular pneumonia there is suppurative inflammation. Mode of healing, usually this lobar pneumonia there is resolved patient occurring in the most of the cases, while the lobular pneumonia there will be lysis and complications are more common. They are worst, they are badly infected patients. Lobular pneumonia worst conditions. So we have seen in histopathological examination also, lobar pneumonia they will have 4 stages: stage of congestion, red hepatization, grey hepatization, and resolution. While the bronchopneumonia or lobular pneumonia, they don't have the 4 stages. They will have only 1 stage of infection. And in chest X-ray, in lobar pneumonia, there will be opacification of the entire lobe. While in case of due to patchy involvement, you will see patchy opacification. Clear? Any doubts? You can ask. So pneumonia clear. So moving on to next part, that is the lung abscess. Pneumonia, everything is clear, because difference will be asked in Viva also, in MCQs also, right? All the stages, everything will be asked, because that is an important topic, pneumonia, and you will get lot of cases in clinical postings also. At that time these things will help out. So lung abscess. What is lung abscess? It is localized the collection of the pus that generates developing in response to infection. It can be aerobic or anaerobics. In aerobics, it is mostly caused due to Streptococca and Staphylococcus aureus, while in anaerobes it can be bacteroids, Fungobacterium, or it can be Peptococcus. It is of 2 types, lung abscess. It can be primary or it can be secondary. So primary develops in otherwise normal lung. For example, commonest cause is the aspiration. We have seen why aspiration occurs and which patients or which persons they are more common to develop the aspirations. So primary lung abscess, they can be developed due to the aspiration of the materials or infected particles. And the secondary lung abscess, it develops from the complication of the some other disease of the lung or from the another site. So the term pulmonary abscess describes the local suppurative process that produces the necrosis of the part of the lung tissue. It causes complete necrosis. So it can be due to the oropharyngeal surgical or dental procedures that leads to the infection and affection and necrosis of the lung tissue. It can be due to the sinobronchial infection, or it can occur in patients with bronchiectasis. Secondary infections or secondary lung abscess. So in etiopathogenesis, there can be aspiration or preceding to bacterial infection, that is post-pneumotic abscess, or it can be due to bronchial obstruction. Either it can be primary or secondary due to malignancies, and it can be either due to septic emboli from the infective endocarditis or thrombophlebitis, that this infective focus that goes and stuck up in the lung, distal part of the lung, and that causes the secondary infection and formation of the lung abscess. Other causes are miscellaneous, like direct traumatic injury to the lung and spread of infection from the neighboring organs. On other, there can be cryptogenic lung abscess also. In morphologically, any part of the lung, or it can be single abscess, or it can be patients may have the multiple abscess also. So it varies from the few millimeters to larger in size, varying from 5 to 6 centimeters. As complications of pneumonia, so these can be secondary to the suppose the patient didn't get treatment, and in long duration of the course, if they didn't receive any treatment, these pneumonia patients or bronchiectasis patient, they develop the lung abscess, and they can be multiple, basal or diffusely scattered, or it can be single also. So this is gross image from the lung parenchyma with lung abscess. This image is from Robbins' textbook only. You can able to see there is a well demarcated cavity, and this cavity contains the exudative material, pus material. So if you see the microscopic examination, there will be destruction of the lung parenchyma with suppurative exudates in the lung. However, it's depend on the stage, either it is acute or chronic stage. So in acute lung abscess, there will be neutrophilic granulocytes, and that will be in the dilated blood, along with dilated blood vessels and inflammatory cell edema. And in chronic lung abscess, there will be presence of lymphocytes, plasma cells, and histiocytes. So all these cells, they demarcated the chronicity. There will be presence of lymphocytes, plasma cells, and histiocytes around the layer of pyogenic membrane surrounded by the abscess. So this is the microscopic image. So this image is from the abscess cavity of the lung. You can able to see there is a nuclear debris. So there is a nuclear debris in the lung tissue, and there will be collection of these numerous polymorphs along with dead tissue fragments, and they are surrounded by numerous polymorphs, few RBCs, red dot, and there is cellular debris. But when the days go off, and this area will be, there will be central necrosis, and this surrounded by the lymphocytes, histiocytes, and plasma cells. If you go and have a higher power, you will be able to see. So in clinical picture, these patients may have the purulent expectoration or hemoptysis, or they can have fever, malaise, weight loss, and cough. So moving on to further, so we have till now we have covered the pneumonia and lung abscess. Clear? I am audible? So these things are common. So there are few images which are given in Robbins' textbook. So these are the fungal infection which can causes the chronic pneumonia. So what you are seeing here is the chronic pneumonia caused by the Histoplasma capsulatum. Histoplasma capsulatum is a type of fungus, and you can able to see there are budding yeast, numerous budding yeast, and this is special stain which with the
silver methanamine. And what happens in this one, histoplasmosis? They will form this granuloma also. If you see microscopically also, there may form the granuloma, this fungal infection. And the gross appearance is typical. They will have the tree bark appearance. There will be concentric layers of fibrosis. And these concentric layers of fibrosis, it will mimic with the tree bark. So you may get in multiple choice questions also this image from the chronic pneumonia, patient suffering. This can be immunocompromised patients as they are getting fungal infection, and these images may be shown and it will be asked what is this condition. So you can able to see these whorl-like structures. So there are layer by layer fibrosis, and this is tree bark appearance of the nodule which is affected in the lung, and it is infection from the Histoplasma capsulatum. It is a type of fungi. Second is blastomycosis. There are chronic infections. I am just showing you the images. Again, this is a type of budding yeast forms. You can able to see here thick walled fungal hyphae, fungal structures, and they will have the central nucleoli. Right? You can able to see some nucleus-like structures. Other fungi, they don't have nucleus. Right? So this is fungal infection that is caused by the blastomycosis. They are rounding budding yeasts. And another is coccidioidomycosis. Coccidioidomycosis, it is again a fungal infection, and they will have these spherical-like structures. And these spherules-like structure, they will have the endospores. This is higher magnification from this one. You can able to see they will have normal, this one big spherule, and that big spherule have these small round structure, what we call the endospherules. Thank you. Till now any problem? You can ask from pneumonia, lung abscess, or these chronic infections also. Atypical pneumonia, they are usually infections caused from the viruses and fungi, right? They will have the infection in the interstitium part. They don't involve the alveolar sac or bronchioles, right? They will involve the interstitial spaces. There will be interstitial involvement in infection, right? And whatever we have seen here, the pathology, the major part affected will be the alveolar sac and terminal bronchioles. You will see inflammatory cell in between. Whatever the interstitial spaces will be there, that will be either thickened or they will be clear, right? So what happens in interstitial pneumonia? You will get lot of inflammatory cells in between these interstitial spaces, right? If you have, I will cover in the next lecture. If you want to have interstitial pneumonia part also, I will another explain in upcoming lecture, right? Okay, take your time.